Good morning, everybody. Thank you so much for joining us again in this rainy Thursday. And today is March 17. I'm Sandra Arevalo, and I'm the Director of Community Health and Wellness at Montefiore Nyack Hospital. And today we have Dr. Benjamin Garrell with us. He's going to introduce himself because he has a lot of background and very important background too. And the topic for today is all about men. We're going to be talking about different issues that are of concern to men. So if you are a male, you're in the right place. And if you are a woman who loves a man in your life, a man in your life, like a wife, or you're a mother of a son, or you have a boyfriend or a father, some male that you care for, this is for you too, because it's good that you learn everything that we're going to be talking about today. And you bring it home back to them. And that way it's a great way to show love as well, isn't it, Dr. Gartrell?
Definitely is. Thank you for having me, and thank you for everybody that's attending so far. I will be looking out for any questions. I'm happy to address anything as we go. So yes, I'm Ben Gartrell. I am a genitourinary medical oncologist. So that means that I help treat cancer by prescribing appropriate medications. I am at Montefiore Medical Center, where my primary responsibility is to be the director of genitourinary oncology. So I help patients with certain cancers: prostate, bladder, kidney, testicular cancers. So I see primarily men. We think about men's health literally every day that I'm in clinic. I'm actually in the middle of clinic now, and I'm dealing with men's health before, during, and after this meeting. So this is something I think a lot about. These are very important topics. I'll say that I've been here in Montefiore leading the program for 10 years. As of July, it will have been 10 years, and the time's gone quickly. But it's been a remarkable time in the treatment of the illnesses that I take care of. There have been many advances. We take advantage of them here. We treat patients with standard of care. We also treat many patients in the context of clinical trials. Whereas I'm a medical oncologist, we work with many other important doctors, and quite frankly, I couldn't do too much without all the help that we get from radiation oncology and urology and nuclear medicine and pathology. And I work with an incredible research staff and also clinical nurse practitioners and PAs that allow me to do a lot here. But that's sort of what I am. It's what I do. I have a great passion for providing the best care to patients that have these malignancies, both in terms of standard of care and clinical trials. And I'm looking forward to having this conversation today.
Okay, well, thank you so much. And we know that you're busy and in the middle of the day, so I'm really, really thankful that you're spending some time with us. And let's get into business. So what, according to what you see in your practice, what do you think are the top health concerns of men?
Sure. So I'll focus primarily on cancer, since that's what I do. Clearly, there are very important health issues that are not related to malignancy. But one of the things that I try to stress, and we've hosted some community events here in Montefiore, but cancer screening is a very important topic. And I think it's really important that we focus on it now. We're 2 years into this pandemic. I think a lot of routine healthcare has actually been delayed. Or maybe, I think a lot of us are behind actually with the appropriate routine healthcare, including, cancer screening. So with the cancers that I take care of, I'm primarily concerned that patients have conversations about prostate cancer screening. And this is something that has been a controversial topic, and understandably so. So, if we look at the number of cases of prostate cancer in the United States, in the early 1990s, the number of cases went much higher. And I don't think that there was actually much of a change in terms of men's health, but the big change was we had a new blood test called the PSA, for the prostate-specific antigen. And if we checked it in our patients and we identified an elevated value, that made us concerned for prostate cancer. And that led to many more diagnoses and treatments. So for a period of time, the pendulum went one way, where everybody was getting screened and some patients were possibly being overtreated. But then the pendulum swung, I think, the wrong direction, too far. where all of a sudden recommendations were that we should avoid PSA screening because there was a concern that maybe some men were overdiagnosed and overtreated. But now it's, I think, come back to bite us a little bit. So we are seeing now more men die of prostate cancer in the United States on an annual basis for the last several years. And I think it's probably because we are not doing enough screening. So where I'm at in Montefiore, the vast majority of patients I take care of are minority patients. And I feel like this has been a particular disservice, particularly for Black men, for reasons that we don't necessarily understand, but something that we've observed. Black men are more likely to be diagnosed with prostate cancer, and it tends to be more aggressive prostate cancer. So we've actually looked at our numbers here at Montefiore, and we've published on this topic. And what we can see is that by self-identified race, if somebody says that they're Black, they are about 3 times as likely to have stage 4 disease at the time of prostate cancer diagnosis here in the Bronx. The best way to prevent bad outcomes for prostate cancer is to identify it early before there are symptoms. And that's where prostate cancer screening is critically important. So I will say I'm an advocate for prostate cancer screening. I think that it's critically important that men, when they get to beyond the age of 50, and for minority patients or patients with family history, 45 or older, they begin to have conversations with a primary care doctor about considering prostate cancer screening. The most important test is a PSA blood test, and possibly also in combination with a digital rectal exam with your provider. So that's a major concern that I have. Obviously not the only issue for men's health. You know, all of the issues that we need to be thinking about, from having appropriate vaccinations to making sure that you have a good, healthy diet, that patients are not overweight, critically important not to smoke. These are the things that I think that we need to focus on. And I think that mental health deserves particular attention these days, particularly 2 years into the pandemic. I think that it's been a trying time for our country and the world. And you know, that's an important topic for conversation. But those are some of my initial thoughts. I've probably gone on too long as I do. So
no, that's perfect. That's perfect. And as you're talking, I'm thinking, you just mentioned signs or symptoms that we should be aware.
Mm-hmm. Yes, when thinking about, you know, prostate cancer in particular, you know, we want to actually diagnose it before there are any signs or symptoms, and that's when screening comes in. However, it's very common as men get older that we start to have some issues with urination. And actually the most common causes with the problems with urination typically are not related to cancer, but there's a condition called BPH, benign prostatic hypertrophy. And what happens is, as men get a little bit older, the prostate tends to become enlarged. And sometimes when that happens, it can actually have a negative impact on urination. But certainly, you know, urinary symptoms are something that we think a lot about in the patients that I take care of.
Mm-hmm. Are these tests that are regularly done in like a physical, or how do you get to know your numbers?
Yeah, sure. So it used to be very routine that anytime a man over a certain age would go to see their primary doctor for their annual physical, that a PSA blood test would be a part of it. However, as I mentioned, there was some controversy for a period of time. The major body in the United States that gives recommendations on cancer screening said that we should not be screening for prostate cancer because of a concern for overdiagnosis and overtreatment of low-risk prostate cancer. So sometimes these days, it's not part of the annual evaluation. Now, what I want to advocate for is, I think every man should have a conversation with their doctor about cancer screening. That should include colonoscopies. It should include a conversation about a PSA and a digital rectal exam. It should include a conversation about imaging of the chest if somebody is a smoker. But it's really critically important that these conversations are had. Since I think in some practices, prostate cancer screening has kind of not gotten the priority that it once did, sometimes conversations are not had, PSA tests are not checked, and sometimes we don't identify the problem until it's out of control. But this easily is a part of the routine evaluation on an annual basis with a PSA blood test and a rectal exam.
Mm-hmm. Now, I know that a lot of people, and it might also be a cultural thing, they are against the digital rectal exam. What can you tell us about it?
Sure. So rectal exams, nobody's favorite topic. Some patients refuse them, but as providers, this is part of our routine. What we do for patients all the time. We like to think it's not a big deal. Hopefully, just minimal discomfort. Typically, this is something that can be considered on an annual basis. When we do a rectal exam as a physician, I'm primarily interested in the prostate, but also we're evaluating for any abnormality within the rectum. So this is also a part of colorectal cancer screening. There is generally not a reason to do an examination like this unless there's a particular concern more than annually. Certainly, generally, you don't need it any more than annually. But I saw that there was a question here about how often it should be done. But I think for a man over the age of 50, an annual digital rectal exam is a reasonable consideration.
Mm-hmm. And you also mentioned earlier about family history. My question is it family history of prostate cancer or any cancer or something else?
Yeah, that's a really important question. So I'm thinking largely about prostate cancer, certainly a history of prostate cancer within the family with a first degree relative. And by that, we mean parents, brothers, sisters, children. If there's a first degree family history of prostate cancer, we're worried. And sometimes we do see these cancers aggregating within families. Now, one thing that we've also learned about prostate cancer is that some of the genetic changes that are associated with things like breast cancer and ovarian cancer, the changes in BRCA, sometimes called BRCA, BRCA1 and 2, are also something that can predispose to prostate cancer. So when I'm taking a history from a prostate cancer patient, I don't just ask about prostate cancer, I ask about malignancies in general within the family. And I don't even specify for a first degree family member because I want to hear everything, but it's really those first degree family history that is most critically important. Primarily interested in a prostate cancer family history, but sometimes other malignancies, like for instance, as I mentioned, breast and ovarian cancer are things that we think about. Also, sometimes we might help to identify some other issues that we're not necessarily thinking about. For instance, we might find that there's a strong family history of the colorectal cancers, and we need to think about some other potential syndromes. But one thing that's become very routine since I've been here at Montefiore is for patients that have high-risk prostate cancer or stage 4 prostate cancer or prostate cancer and a significant family history for other malignancies. We make sure to offer those patients a referral to genetic counselors. And many times those can actually be video visits. And then if appropriate, the patient can come in for a blood test or a cheek swab, or sometimes those tests can even be mailed to the patient's home, collected, and then sent in for an analysis.
And I know, like, for example, for women, we should be doing the breast exam as a way of screening. Do men have similar tests? Because I know that men can also suffer from breast cancer. And I don't know, are there any screenings like that for prostate or other types of cancer for men?
Sure. So we don't do routine screening for breast cancer in men. It's about 1% of breast cancer occurs in men, so it can happen, but it's fairly uncommon. The primary screenings that we think about for men are prostate cancer, again, PSA blood test, a rectal exam, colorectal cancer. So the primary ways that we screen for that has changed a little bit. So there's actually something called Cologuard, which is a test, a molecular test that you can collect for yourself at home from a stool sample and submit for an analysis. Of course, there is something like a colonoscopy, which is probably the most common, or sometimes primary care doctors will provide what are called fecal occult blood tests. So you would collect a sample of stool, send it for analysis, and we look to see if there's blood in it. But certainly colorectal cancer screening is an important topic and is recommended. And then, we hope men haven't smoked or don't smoke, but it's important that we talk about if they have smoked. If a patient has a significant smoking history, then it also makes sense to periodically consider low-dose chest CTs to evaluate for any sorts of lung masses. But these are the sorts of cancer screening tests that we're talking about and discussing with men on a regular basis.
And Yubi is asking, she says, I would like to add on to that question, if that's okay. Women are often advised to self-examine their breasts for lumps. Can men conduct a self-exam too?
Of course, definitely. Now, let's think about, what makes sense to examine. So We typically are not recommending breast self-exam just because it's very unlikely that a man has breast cancer, but it is possible. Clearly, if a man notices an abnormality, we want them to make us aware. I have been doing this for a long time. One of my patients has been diagnosed with breast cancer. So it can happen and we don't want to disregard it because they certainly can occur. The self-exams that we're mostly talking about in patients that I've taken care of are testicular self-exams. Particularly if a patient has a history of testicular cancer, that would mean that they probably have had one testicle removed and they're at risk in the remaining testicle of developing a malignancy. Also, if men have been not had a testicle that's not descended at the time that they are born, they also have an increased risk for testicular cancer. So it would make sense to consider a self-examination in that context. Testicular cancer is pretty uncommon. It tends to occur mostly in young men. It tends to be fairly uncommon diagnosis as men get older, but that is something that we sometimes consider, primarily in those patients who had a history of being treated for testicular cancer at sometime earlier in their lives.
And how often would you have to do like that screening for testicular cancer?
So there's no screening test that we normally do for testicular cancer because it's uncommon. But we would mention to men, if they're in the shower and they notice something abnormal, the primary number one indication for testicular cancer is a painless mass on the testicle. So it's usually not painful, it's typically painless. And if a man notices a painless mass, obviously that's just something we would need to think about and evaluate really quickly. If I take care of a patient who has recovered from testicular cancer and has a remaining testicle, I ask them when they're in the shower and they're cleaning themselves to pay attention. And generally I ask them to consider, a brief self-examination, maybe on a monthly basis in the shower.
Mm-hmm. Let's move away from that topic a little bit and let's talk about testosterone. There are a lot of changes of testosterone during a man's lifetime.
Sure.
And how do those changes affect the body of a man? Some might be good, some might not be that good.
Sure. I will say that I have a fraught relationship with the hormone testosterone. And what I do, it's often the enemy. So we are always finding a way to try to suppress it. At the same time, clearly testosterone is important for normal male health. So when I take care of prostate cancer patients, unfortunately, if they have stage 4 disease and the cancer has spread in their body, the primary way that we have fought prostate cancer that has spread in the body for really about 80 years is we make testosterone go low. And we primarily do that these days with either hormone injections or a recently approved hormone pill, or it can also be done by a man electing to have both of their testicles surgically removed. So I'm often fighting testosterone. At the same time, I've seen many, many men suffer through the side effects of low testosterone. So I try really hard to only suppress testosterone in men who I think are really going to benefit from it. Sometimes we lower testosterone for prostate cancer that has not spread in the body. For instance, if men are treated with radiation, sometimes for a period of time they get low testosterone therapies because that improves the outcomes with radiation. So what I attempt to do is I attempt to give a man the shortest appropriate duration of hormone therapy. Sometimes we see men who have been treated for prostate cancer and in their future, their PSA is rising, but on scans, they don't have any evidence of cancer. And also they don't have any symptoms. In that situation, I try my best to avoid using hormone therapy just to reduce the PSA because there are so many potential side effects from lowering the testosterone. So when I do lower a man's testosterone, we often think of this as similar to menopause in a man. So sometimes we call it menopause or andropause. There's some cute terms that are used, but the side effects are not cute at all. And the major side effects that I talk to patients about include things like sexual side effects. So inability to have an erection, loss of libido, a decreased size in the genitals, which is something that is not commonly discussed, but is commonly experienced by men with low testosterone. We see many changes in the body. We see a loss of muscle mass. We see a loss of bone strength. I often will talk about sports because I'm a big sports fan. I say that, Barry Bonds took testosterone, hit 73 home runs, but I have to make it go the opposite way. So I worry that men may hit fewer home runs the next season. But it's major concerns. We also see a gain of fat, particularly in the midsection. We see a change in distribution of body hair. We see mood being impacted, and that's something that is not necessarily always discussed, but mood is negatively impacted when we lower testosterone for sure. Lowering testosterone can increase the risks of cardiovascular disease like heart attacks and strokes. There has been an association with lowering testosterone and increased development of dementia later in a man's life. And some men will just say that they feel like there are some cognitive changes that they notice as we suppress testosterone. So there are many negative impacts of testosterone. I hadn't even mentioned them all, things like growth of breast tissue called gynecomastia or nipple tenderness. Hot flashes are very common if I hadn't said that. So there are a lot of negative things that can occur. I will tell you though, that men's experience is quite varied. Sometimes men say, Dr. Gartrell, you made it sound terrible and it's okay. And other times men are miserable. And what I'll tell you is we always think about the individual patient. What is their indication for lowering their testosterone? And if we can, we try to give a shorter duration of therapy or breaks when men can hopefully have a return of testosterone toward normal levels. But yes, low testosterone is something that has a lot of potential negative side effects. Now, for the normal man, we're somewhat fortunate in that we make testosterone throughout our lifetimes, whereas women stop making estrogen at the time of menopause. Now, the normal testosterone values do decline as men get older. So when we look at normal age ranges, there's always a decrease as men get older. And many times there's an association between some of the things that men may experience as they get older, if it's either changes in sexual function or changes in energy or other changes are sometimes associated with a lowering of their testosterone. So sometimes men will choose to have a testosterone supplementation. I will say that that's something that I don't necessarily prescribe, but we work with endocrinologists that sometimes help. Occasionally the issue comes up where we treated a man with medicines to lower their testosterone, and then maybe the testosterone has not recovered after we've finished their prostate cancer therapy. Occasionally we will consider giving a man supplemental testosterone. It is somewhat controversial, but there are certain situations that we think it's appropriate, and we have our endocrinologists guide patients through that process.
Wow. And is urinary incontinence another symptom that we need to take into consideration?
Well, that is a common consequence of prostate cancer therapy. So when a man is diagnosed with prostate cancer that's just in the prostate, and they're recommended to have therapy. So I will say that some men don't require therapy. There's something called active surveillance or observation where we're trying to avoid treatment. But for many men, particularly if they're younger, healthier, and have more aggressive prostate cancer, they need therapy. And typically the therapies that we're thinking about are either surgery to remove the prostate or radiation, sometimes in combination with hormone therapy. So when we talk to a man about their personal preference, because they may have an option to choose one or the other, radiation or surgery, we will talk sometimes about what are the different experiences, what are the different potential side effects. Certainly, it's more common for men to have permanent urinary incontinence if they have surgery to remove the prostate, in comparison to men who've had radiation to the prostate. So yes, urinary incontinence is something that major negative impact on quality of life, and it's a fairly common consequence of having been treated for prostate cancer, particularly with surgery.
Erectile dysfunction. I know that a lot of men have issues with that. Mm-hmm. You don't feel well when you're having ED. Mm-hmm. How does ED relate to all of these?
Sure. So erectile dysfunction is a very common topic in my clinic. It's something that sometimes men are uncomfortable bringing up. It's sometimes considered a taboo subject. I'm very comfortable talking about it. I will specifically ask the men about it. It's really critically important that if a man has negative impact from prostate cancer therapy or just otherwise, and it's having a negative impact on quality of life, we want to talk about it, because sometimes we have resources that can be considered. So if a man has erectile dysfunction, we will often think about, what's the cause? Many men that I take care of the causes, they were treated for prostate cancer or they're on low medicines that lower testosterone. Of course, men can just have erectile dysfunction unrelated to it. Sometimes it's more likely if a man has an issue with diabetes or high blood pressure that's been poorly controlled over years. But there are options. Many men are aware. I think everybody probably is aware that there are pills that can be considered. Sildenafil is the generic term for Viagra. There are similar medicines. Cialis is one that comes to mind. But these are the sorts of medicines that can be prescribed, sometimes effective and sometimes not effective. Actually, in the context of low testosterone, those medicines are not that effective, I've got to say. And essentially, they don't really help with libido, so the interest. So there's a combination of the lack of interest, also the lack of the ability to have an erection. Mm-hmm. So there are a variety of things that can be done beyond prescribing a medicine like Viagra. For instance, we have a urologist named Pedro Maria that works here at Montefiore, who has helped many men who have suffered negative sexual side effects of prostate cancer therapy here in the Bronx over the years. There can be therapies that can be actually injected into the penis that allows a man to have an erection. And some men will choose to have a surgical procedure that allows themselves to have a pump that also will allow them to choose the time at which they would want to have an erection. Also, Dr. Maria helps with things like urinary incontinence, which can be, a major negative side effect after prostate cancer therapy. So the reason I bring all these things up is I just want men to be aware that we have resources that can be offered, as do other medical centers, that can potentially address some of the negative side effects of prostate cancer therapy. And we want to try to improve a quality of life, and certainly sexual function has a major impact on quality of life. And there are options that can be considered. And, it's important that we have these conversations.
Yeah. And you, at some point just now, you mentioned diabetes. And we have a question from Marguerite here. If a man has diabetes, can this man be a candidate for prostate cancer?
Sure. So I would say that the number one risk factor for prostate cancer is obviously being a man. Number two is getting older. So this is a diagnosis that's much more common as men get older, for sure. The other things are family history. Does diabetes have any impact on the development of prostate cancer? Maybe, but it wouldn't be among the top contributors for an increased risk for prostate cancer. I think that if a man has diabetes, they should be screened for prostate cancer, just as a man who does not have diabetes should be offered screening for prostate cancer. Certainly, if a man does have diabetes and they're diagnosed with prostate cancer, it can have impacts on the conversations that we have about what's the best way to treat them. Clearly, if I'm going to give them hormonal medications, I have a greater concern about their cardiovascular health. Also, when we lower testosterone, it can have a negative impact on blood sugar control. And some of the medicines that we give for prostate cancer, including abiraterone, Zytiga, which we use with prednisone, can increase blood sugar. If a man has diabetes, sometimes there might be a little bit less enthusiasm for offering that individual patient surgery, and maybe they would be more likely to be treated with radiation as opposed to surgery for prostate cancer.
Mm-hmm. Thank you, doctor. And who do you think suffers more stress, men or women?
Well, that's tough. I feel like either way I answer that, I get a lot of negative feedback. But I will say this. One thing that I know is critically important when we talk about men's health is the women in their lives. I have not looked through to see if there's more men or women on the call. I would not be surprised to see if there are more women on the call. To get the lowdown on how a man really is doing, we often have to talk to their wife or their daughter or their sister or a good friend. But it's very commonly a woman that takes an interest in a man's well-being. Mm-hmm. that really helps a lot and functions as a primary caregiver or advocate, somebody that can help digest the information. So I will say this: I think that when a man has a diagnosis, the women in their lives suffer a significant amount of anxiety associated with it. There's no doubt about that, and I think that they help to offset some of the anxiety that a man would suffer from. So we actually have a program here at Montefiore called the BOLD program. And it's, I think of it as a cancer support group, but it's not just for our cancer patients, it's also for their caregivers. And, we encourage the loved ones or friends to participate in those conversations as well. But, undoubtedly, men benefit from women being involved and concerned about their health and well-being. I think that's very clear.
Yeah, and indeed, I was just looking, and yes, we do have more women than men in the call. You know, my feeling is that women are always more concerned about health issues than men. That's just in my experience also. And let me see. What about physical activity? Like, do men need to have certain types of exercise that are different for women? How much exercise?
Yeah, wouldn't it be nice if just sitting in the couch and eating potato chips would take care of all these problems, but it doesn't. So particularly when I treat a man for prostate cancer, you know, sometimes there's this concern that being active or lifting weights is bad because it can increase testosterone, or maybe taking Viagra is bad for their, you know, prostate cancer. And I say, no, none of that's true. So it's really important. I ask men who have prostate cancer to be active. The activity, number one, helps to minimize unwanted gain of fat in the abdomen. Certainly weight resistance exercises, like even lifting light weights, is really good to offset the loss of muscle and bone strength. Fatigue is a major negative impact of being treated for prostate cancer. And it turns out that one of the best ways to address that is being physically active. Also, physical activity is really good to offset the negative impacts that mood from lowering testosterone. So there are many, many reasons for which I encourage men to be active. This is also an important thing about men's health and overall health. I think that it really requires a conversation now that we've been dealing with the pandemic for 2 years. I think that there was a lot of unwanted weight gain, a lot of increase in sedentary lifestyles. I think that, you know, many times people were concerned about just getting out there and being active. Certainly many people that had gone to the gym had decided they shouldn't go to the gym. I think that just in general, there have been a lot of changes in our lifestyles that have many times, unfortunately, been negative for our health, including drinking more alcohol and, you know, sitting on the couch more and watching more Netflix and all these sorts of things. But, you know, I encourage, you know, do what you can. Everybody is coming from a different place. Sometimes as we get older, we have problems with our knees or our joints or our backs. But we really just need to think about the individual that we have and trying to encourage them to be able to be as active as they can be. And then I ask, you know, to pay attention to feedback. So many times if a man has prostate cancer or some other condition, they're worried that if they push it, they can injure themselves. I usually say something like, it's very unlikely that the first indication of a problem is going to be something devastating. Usually, if you start to notice that you're doing an activity and it's causing you pain, your body is sending you that signal for a reason, you should respect that, modify your behavior, talk to your doctor about it. So I encourage physical activity. I'm particularly encouraging, you know, patients as the weather gets better and the pandemic is improving to get out there, go for a walk. Going for a walk is a very effective way of getting cardiovascular exercise. The heart rate increases. It's good for your strength. It's good to minimize unwanted weight gain, to burn calories. You know, also here at the Cancer Center, we have nutritionists that are really effective. And sometimes patients are resistant about talking to nutritionists. They say, oh, it's all common sense. But at the same time, there's a major issue with obesity in the United States, and I think it deserves particular attention. And sometimes even fairly minimal changes in a diet can have a major impact on health and well-being. Things like removing the starches and having a salad instead, don't put on the high-fat dressing, you know, these sorts of things that, you know, we can think a lot about. But yes, I encourage men to be as active as they can. I tell them I run every day. And I look forward to them running past me in the park.
That's great. Now, Yubi's asking, and Yubi, nothing to apologize about, is what are some natural ways to help men with erectile dysfunction and stamina?
Sure. So things that come to my mind, and particularly for stamina, you know, having a healthy lifestyle. Right? I think that's just kind of common sense. But these are the sorts of things that these are changes that take time and dedication. And certainly being active, having a healthy diet, being a healthy weight are really, really important. You know, also the things that we can do to avoid certain sorts of negative complications of things like diabetes, high blood pressure, smoking. All of those things contribute to things like erectile dysfunction or, you know, pulmonary diseases that are going to make a man more sedentary. So I really think that for a man to avoid these sorts of things, they need to be focused on their health and well-being starting at an earlier point in their lives. And they're, you know, what do they say? An ounce of prevention is worth a pound of cure, or something like that. But certainly focusing on health and well-being earlier at the time in a life and being consistent about it over a long period of time certainly pays off as men get older. Undoubtedly, you know, obesity, high blood pressure, diabetes, smoking are some of the major things that are going to contribute to erectile dysfunction, loss of energy, depression, and shorter life expectancy.
And JR is asking also if there are a natural way or natural supplements that can help prevent many of the problems that we have discussed today.
Well, I think that, as I said, there's no replacing a healthy lifestyle. Now, there actually is an FDA-approved medicine that can be used to reduce the chance of developing prostate cancer. There's medicine finasteride, which can be considered. So sometimes, you know, I've had experiences where I've talked to patients who have sons, or maybe I've spoken to younger men who have fathers who've had bad outcomes from prostate cancer, and these are things that we can talk about. So there is a preventative medicine that could be considered, not used particularly often, but for an appropriate patient at higher risk, it's worthy of conversation, finasteride.
Diet. Do you recommend any specific diets or any changes in dietary habits to patients?
Sure. I wish I could just say it was Oreos and donuts, but it's not. You know, what I usually say some common sense things, and then I have our nutritionist take it from there. But something that I do myself, I look at the thing I'm about to eat and I look at the ingredients. I want to see a short list of things I know. If I see a long list of words that I have a hard time pronouncing, it's probably something that's not in my best interest. So what I'm thinking about is avoid processed foods. You know, eat whole foods when you can. Processed foods tend to have a lot of chemicals that we don't want to really ingest. They tend to be high in sodium. They tend to be injected with those sorts of things that, you know, add salt, fat, flavor that aren't necessarily in our best interest. You know, clearly a diet high in fruits and vegetables is in our best interest. Avoiding refined sugars is clearly something that I think is in our best interest. And probably the most important thing is just making sure that we maintain a healthy weight and without being obese, because certainly obesity contributes to major negative health impacts, you know, beyond the possibility of an increased risk for cancer.
Okay, I don't have any more questions for now, but I encourage all of our participants today to keep sending us questions, because we still have a couple of minutes and we're not going to have Dr. Gartrell anytime soon, right?
I do see some more questions. I see one just got posted here.
Yeah, one more. Like, are there specific triggers for cancer, like the VPA?
You know, so I'm not aware of that one in particular, but certainly when I think about the cancers that I treat, generally carcinogens are not a major cause for prostate cancer. However, carcinogens are a major cause for things like bladder and kidney cancer. So, you know, one thing that, you know, I really stress is that the major carcinogen that should be avoided is smoke. Whether it's secondhand or firsthand. But, you know, certainly smoking contributes to, we think of lung cancer, or we think of, you know, head and neck, throat cancers, we sometimes think of it that, but, you know, pancreatic cancer, cervical cancer, penile cancer, bladder cancer, you know, kidney cancer. I don't remember if I said pancreatic, but certainly exposure to certain carcinogens is very bad. As I take care of patients that have bladder cancer, I'm often thinking about this. The bladder is the repository for urine, obviously. It also is the repository for some carcinogens that are excreted from the body in the urine. And some of the carcinogens from smoke are. There are certain industrial compounds and dyes that are used for certain industrial processes that we also know can increase the risk of things like bladder cancer. But the number one carcinogen that should be avoided at all costs to reduce cancer risk is definitely smoke.
Now, many men out there, they suffer because, you know, the hair starts to fall and they're always looking for remedies for falling hair. So what do you usually recommend?
Yeah, sure. So, I mean, there are approved medicines that can be considered. You know, nothing is a sure thing. You know, there's the topicals, things like minoxidil that can be considered. There's also the medicine finasteride, which I've earlier mentioned. So it is approved under several different names. For preventing hair loss or treating it, it's known as Propecia. It can be pretty effective. I think it got a lot of attention when Trump was talking about he and his doctor both having taken it. But there are medicines that can be considered. At the same time, every medicine that we use has the potential for negative side effects. And then also, you know, these medicines, in order to be effective, would need to be continued for a man's lifetime. So these are things that would just need to be considered. This is something that you're willing to do for decades because you're concerned about losing your hair. So yeah, these are things that don't come up so much in my clinic because I mostly take care of older men that, you know, have a diagnosis of cancer. But clearly these are things that younger men, you know, need to be thinking about. Clearly, you know, male pattern balding is a common occurrence, you know, which causes a lot of stress and anxiety, particularly as it gets started.
Yeah. And MK is asking, my spouse is a testicular cancer survivor. He was diagnosed when he was 39 years old. He's now 53. How often should he see an oncologist? The last time he went to one was 7 years ago.
Well, you know, it's a good question. And quite frankly, it sounds like, fortunately, he's cured. So he probably doesn't necessarily need routine follow-up after 5 years removed from therapy. At the same time, we have to think about how an individual patient was treated. When a patient's treated for testicular cancer, I mentioned there's an increased risk for testicular cancer on the other testicle, so self-examination makes sense. If a man's treated with chemotherapy, that increases the risk of second malignancies. A variety of second cancers, actually, from leukemias to solid tumors. I certainly have noticed in my own patients that I take care of that many patients who have been treated earlier in life for testicular cancer tend to have metabolic abnormalities and fatty liver. I think that they need to be seeing somebody periodically who's at least tuned in to the possible consequences of the therapies they were provided. When I see a testicular cancer patient that's now 5 years removed from therapy, I usually offer them congratulations. I tell them the chance of your particular cancer coming back is extremely low. Never zero, but a very, very low percentage chance of a cancer recurrence. I tell them you don't need to see an oncologist because you don't have cancer. However, I'm happy to continue to see you on an annual basis. And at the minimum, you need to make sure that you see a primary care provider that's in tune with the potential long-term negative consequences of having been diagnosed and treated for testicular cancer.
Mm-hmm. And I think we have 2 more questions here. Radiation. FJ is asking radiation.
Sure. So I didn't see the specific question, but you know, radiation.
Radiation, yeah.
Okay. So radiation in the context of prostate cancer is a very effective way of potentially eliminating cancer. So radiation is what I refer to as a local therapy, just like surgery. So surgery is a local way of removing a tumor. Radiation is a local way of providing radiation to try to eliminate the cancer where it sits. Of course, radiation has, you know, negative connotation. We think of things like nuclear weapons, you know, Chernobyl, you know, disaster. Radiation can have negative health consequences, right? I will say this, radiation given by external beam radiation, this is from the machine that targets the cancer within the body and delivers radiation, is extremely advanced compared to where it was previously. So it's given much more accurately now. So we can give higher doses to the areas that we want to treat, which is the cancer, and we can do our best to minimize the potential exposure of normal tissues to radiation. It's never perfect. So when we think about radiation to the prostate, we're thinking about the tissues immediately adjacent. So it sits beneath the bladder and right in front of the rectum. So when we treat a patient for prostate cancer, we think about potential exposure to those areas. Not only is the technology better for, you know, essentially giving radiation with more accuracy, but also these days, sometimes the radiation providers will recommend that a patient have what's called a gel spacer injected. So this is essentially a way of providing a barrier between the prostate and the rectum to minimize exposure of the rectal wall to radiation. But radiation I think of as being safe and effective, but certainly the potential for negative side effects, particularly long-term, which hopefully are minimized these days with, you know, better technology and better ways of mitigating risk.
Thank you, doctor, for the clarification. If somebody would like to get in touch with you,
sure.
Where do they find you?
So I'm in Montefiore. My staff is very responsive. I'm not here to advertise for my particular practice, but overall I'm here to, advocate for the health and well-being of men. Having said that, if there's anything that I can do to help an individual, I'm always happy to do so. Mm-hmm. I will mention my office's phone number if anybody would want to reach out to us. It's 718-405-8505. Again, 718-405-8505. I will say that I'm not always the right doctor to reach out to. For instance, maybe somebody needs a urologist, or maybe somebody needs a radiation doctor. However, if you call my staff and you explain your concerns, we will always make sure that you are put in touch with the correct provider. Mm-hmm. So we're always here. We're happy to provide a resource. That's why we're here and we're doing all this. So if we can do anything to help, we'd like to be able to do that.
Now, I know your specialty is oncology. So if somebody doesn't have cancer, but they, they are suffering from erectile dysfunction, hair loss, these more common symptoms, what would be the best doctor to reach out to for that?
Sure. For urinary problems, it's usually a urologist. Urologists, just like oncologists, come in a variety of different types. So many of the urologists I work with are specifically fellowship trained to be urologic oncologists. Mm-hmm. They also have very good general urologists. Many who have specific interest in dealing with sexual dysfunction from either prostate cancer therapy or just normal changes with aging. For hair loss, typically it can either be a primary provider or a dermatologist. Mm-hmm. For issues related to, say, low testosterone and concern about potential testosterone replacement, that's a good conversation to have with a primary care provider, and sometimes also with an endocrinologist. Clearly for these issues related to nutrition, diabetes, all these sorts of things, just critically important for somebody to have the ability to have a conversation with a nutritionist. I think just a one-time appointment can be very effective. Certainly genetic counseling is important. That's not available everywhere. We're happy to offer that here at Montefiore. And if somebody would have an interest, our genetic counselors here can often do video visits. But these are some of the things that come to mind that I think that a man would want to be thinking about.
Yeah, absolutely. Well, thank you so much, Dr. Gartrell. This was very enlightening, and I hope for our attendees that you got something out of this presentation, obviously, that you run to your doctors, do what you need to do to be healthy. And if you're a woman, because we have too many here, you're taking care of those men you love as well. I mean, sometimes it's very hard to take care of men, I have to say. We, as women, we're more prone to take care of our health and make our appointments and all of that. Men is a little harder. Do you have any advice for women, how we can better take care of the men we love so that they're not saying no all the time to going to the doctor?
Well, I think number one, persistence. I think that's really important. Number two, maybe don't overwhelm with too much at once, but just, hey, how about an annual checkup? That seems like it's in your best interest. And then, what? Sometimes we men, we minimize our symptoms, and sometimes the women that are in our lives are noticing them and observing them. And I think that sometimes the right way to approach a man is not to be necessarily confrontational, scornful, but it's sometimes to just show that you have, empathy and concern. And I think that's probably what women are already doing by their very nature. But I think when approaching a man, sometimes we can be a little bit hard-headed and occasionally stubborn. But I think persistence is probably the best way to make sure that if a man has been not paying enough attention to their health and well-being, that perhaps over time, with some coaxing, maybe they can be talked into being a little bit more concerned for their health and well-being.
Yes, well, thank you so much. I think that's great advice. Hopefully we'll put it into practice and it gets us somewhere. And again, thank you. I know it's in the middle of the day. You made the effort to come to talk to us. And people are saying thank you in the chat as well. It's been great having you. And for sure, I'll be inviting you again, if you don't mind.
It would be a pleasure. Also, I can introduce you to some other members of our faculty and staff that might be good to have on this format as well.
Yeah, that'd be great. That definitely will plan something going forward. And to all of our participants, thank you so much for being here today. Next week, we're going to be talking about multiple sclerosis and the development into that disease and how, you know, the seriousness of it and how does it get diagnosed and all of that. So please join us next week and hopefully we have more sun next week, who knows. But that's all for today. Thank you all.
Bye, everybody.
Yeah.